So welcome back. As you know, PTAC will be issuing a report to the Secretary of HHS that will summarize our key findings from all three of our public meetings on population-based total cost of care. First, we have some time for some general discussion to reflect on what we've learned throughout the day from the various presentations and the Q&A sessions, even though we have more presenters tomorrow. So for committee members, you do have a document on potential topics for deliberation tucked into the pocket of your binder to help guide the conversation. But before we get to that, after our general discussion about what we learned today, we will focus then potential comments for the report to the Secretary. So a little bit later, the staff will walk us through slides summarizing those potential comments. But first, let me just open it up to the committee members for any particular reactions to the day.
I'll open it up.
Okay, thanks, Larry.
With rare exception, and using only scientific reasons to maintain it, I think most of the experts we listened to today would like to see fee-for-service either drastically changed or eliminated completely. And as you and I were just discussing, we've even seen the other extreme was that all physicians should be salaried. So, you know, one of the main takeaways here is that fee-for-service needs drastic repair, and this albatross we have called the RUC has just created an abomination of a system that is doing nothing to help us get fee-for-service under any control.
Thanks for those comments, Larry.
Well, I'll add to that. The irony to me is, and I forget who to attribute this to, but years ago, this might have been Berenson, said, you know, we need to fix fee-for-service before we abolish it. And part of the reason for that came out in some of these discussions. It's scorekeeping. You know, it's not like we think it's a good way to pay people, but it's not a bad way to keep score. But then you have to fix it to keep score right, too. So I don't know. I give up.
But the bottom line was, the best line was from Mark, fee-for-service needs to be less appealing.
Uncomfortable.
Uncomfortable, that was it, yeah.
It's a good line. You know, and one of the things that surprised me about what was a theme I heard from multiple people is incent the organization, not the provider. But then on the other side, I found that in conflict with the theory that the provider should flourish. So I was like, you're almost, yes, and I see how this plays out a lot of times in hospital-based ACOs or payvider organizations where when there's a profit, it doesn't go to the provider. And it's under the auspice of developing infrastructure, but the provider's not flourishing. So it seemed like there was some conflict in thought there.
Hey, Paul, I don't know if you can see my hand raised here.
Oh, I'm sorry, Jay. Yeah, thank you. Go ahead, Jay.
Yeah, one, I totally agree with what Gina just said. You know, when it goes to the organization, the provider suffers, and they don't reap the benefit of their behavior or the changes necessarily, whether it's in future compensation or whatever. The other thing, which was abundantly clear, is no one's figured out how to handle a specialist in a capitated system. And everybody was great on theory today, but when Larry pressed for specifics, we didn't really hear any. And I think the third thing is people have been trying to figure out how to properly compensate primary care for 40 years. And we're still not there. And there just needs to be the mindset of it's an investment. Now, where the capital for that's going to come from, whether we're going to rob Peter to pay Paul, and the overall dollars within the system remains to be seen, but it's got to be addressed.
Thanks, Jay. Yeah, I would think, you know, just to your comments, what we heard from Intermountain around, you know, who should be accountable, and was really and metrics and things. And at least his suggestion was that, it's not just a team effort, but, with advancements in technology, et cetera, it is not clearly going to be a primary care doctor or a specialist who's sort of going to be primarily accountable, but it needs to be sort of this blended. And again, I think he was moving towards, with that the incentive really isn't necessarily primary care specialist, but then it gets back to this around, most of the payment would be sort of salary based with some piece that potentially could be bonus, but as opposed to sort of a incentivizing for specific behavior, whether it's for specialists in particular. Sorry, Lee, you had your hand up, right? And then I think who was next? Jennifer was next. I'm sorry.
Thank you. Yeah, I heard a couple of interesting things today. The first is creating this sense of inevitability that there will be a shift, where there was this sense of both urgency and inevitability before. And I thought it was interesting to hear about the market forces, which are probably obvious, but to state them explicitly in the employer market, around maybe a lack of interest from an employer perspective because they are currently risk adverse to making benefit changes. I thought that was a really important and interesting call out. I also heard, we talk a lot about nested care models, but much to the conversation we were just having, we don't talk a lot about nested incentives and around a deliberate strategy for engagement in each of those tiers that we saw in one of our first presentations. And then this, I feel like we didn't really hear an answer, but what was described as a continuum around moving away from current state, but from everything to making participation in these programs mandatory or at least highly incented. And so trying to figure out what this strategy is around incenting at every layer of care delivery, but that at least many of the folks that we heard from today agree a multi-payer strategy is critical to success.
Great, appreciate those comments. Sorry, okay, thanks, Lee.
Yeah, appreciate next time getting my thoughts in order. I agree with all those comments, but back to Larry's point, I thought it was significant that we didn't hear an answer to what's the magic solution to a value-based or total cost of care model and paying both specialists and primary care. I mean, there may be other deep thinkers, but if the group we had together today essentially said in their silence, there is no magic path. It's total population-based cost of care capitation, whether that's the primary care doctor or a cardiologist for a heart issue, there is an owner that gathers a team of professionals, and that's who owns the risk and the responsibility. And there may be, as an aside, some episode-defined bundles that could work and make sense. That's the answer, I think, to our question, in one sense. So the second observation that I'm still struck by is this concept that what happens in the commercial employer-purchased risk area is going to be the tipping point for what happens in the future of, I took it, healthcare in the country. And that it's really, really scary to feel like how risk is handled in the Medicare population versus the commercial population could go two dramatically different directions. Because I would submit to you that most providers, either physician practice or hospital, cannot operate two different economic models with different incentives. It can't be done effectively. And so it's either going to be we got to thread the needle and find a risk model and schema that can meet the different needs of those two populations, which I think could be done, or we're heading towards just a fragmentation into, disruptive niche market provider organizations that fit only one need and pretty much ignore or abandon the other needs. So I think we have a pretty stark future of one of those two futures will come to pass, and my instinct is her 5 to 10 year time frame is probably accurate.
Thanks, Lee. Angela?
Yeah, I agree with everything that Lee just said too, particularly about the commercial payers. But the other thing that I kept hearing, and I've heard all through the day today, and stuff that we already know, but just made it even more abundantly clear today, is the dichotomy between an organization like Intermountain, because the reason they can get engagement of the specialist, even though they're independent, is because they own 50% of the or at least the majority of the prepayment contracts in that market. And so for the specialist to survive, they've got to be a team player. That's very different than in the rural South, in Mississippi and places where that doesn't exist. And so trying to figure out, it's easy if I own all the contracts in a market to get the specialists to collaborate. We've got to figure out for the rest of the country, beyond those top 12 organizations that do that, how do we engage specialists there, even the primary care docs in those markets who don't even have ACOs in those markets to help pull them together. They don't have the data. They don't have the resources. They don't have those teams. Nobody's providing that for them. How do we incentivize that? Because that's 80% of the population across the country. It's not the Intermountains. It's not the Geisingers, et cetera. So that I'm still at a loss for how to make that happen. So
agree. Wait, I think Josh was next, and then Bruce.
Yeah, that's fine.
Go ahead.
Oh, okay. All right. So I'll go because I'm one off from the previous comment about I admit to having a bit of a bias against high-end consulting groups and their analysis of healthcare, and a lot of them have healthcare practices, as you know. So that remark about commercial risks, I mean, it doesn't sit right with me. I'd like a lot more evidence of that to believe that that's really an important factor. I don't know how it would matter to what we do here anyway, but it's still I don't know. I'm not sure I believe it. Put it that way.
So when you say that, are you saying you don't believe it is what's going to direct how we're going to move into value-based care?
Well, I mean, as I understood what she was saying, is that's the main factor that's going to be the tipping point of how we proceed down the path of health reform or anything else.
Yeah. I would agree with you. I don't agree that that's the tipping point, because it is such a different model. I mean, just from my own personal experience, all of those contracts are all about three things. They're about price. It's all price sensitive. It's all about site of care because of the hospital-based billing procedures, and it's all about hard UM. Those are the three things that every employer hits on, because their populations, typically 80% of them, are not chronic care management, Medicare-like patients. They're young, healthy people with gyms at their workplace, and the ones that we evaluated, their biggest spend over the course of the year was delivering babies, and we couldn't do anything to intervene with that. So there wasn't much we could do other than work on price, educate them, et cetera, et cetera. So, and there are some employers that look a little bit more like Medicare, but it's not Medicare. So the same. And you can spread those teams across. It's just that the effectiveness and the ROI on those patient populations is so small compared to a Medicare population where you're hitting huge chunks of ROI for those teams. It just doesn't make financial sense for a managed care organization to manage them exactly the same way, because it's going to be about price, site of care, and UM for procedures. That's basically what it is.
Sam, Josh, you put your card down. Did you want to make a comment, or? Yeah.
I agree with that, and I'm glad Bruce went first. Thank you. Just shifting from that a little bit, I've written all this kind of in pencil, so to speak, awaiting tomorrow's comments, but I had one overarching comment and kind of three smaller takeaways. The first, from the first listening session, was this idea of, we're focused on payment models, and I think that's appropriate, but what I took away from that was also, step back and see the bigger picture of, if you don't consider MA and APM, then a reform or a change there must be done, and the pure fee schedule. And without those changes, whatever we do within APM, so to speak, may be limited. So that's something that I'll take with me from today. The other three things I heard clearly, Chinny mentioned kind of providers prospering, and I heard this theme of there needs to be an incentive to be in these models. Some of the SMEs talked about the 5% APM bonus. We heard this morning about kind of externally set benchmarks, which ostensibly are meant to create more incentive to be in the, I think Mike McWilliams called it the wedge. But in any case, I think the incentive is there. How we do that, I think, is very important. You know, the APM bonus is useful. I think, as we all know, it's a rate increase, which is anchored in the fee-for-service approach, not necessarily a value-based approach. So how we go forward in creating that incentive, I think, is key. That was the first. The second is I heard the desire across SMEs around simplicity. So a small number of tracks, you know, kind of culling down the number of models. And yet the tension I felt there was also this idea that, well, you can't call all providers efficient or inefficient, that some that take care of high complex patients may be inefficient, but that may be appropriately so. And I started thinking about the organizations that were represented today and how likely in different parts of their care they be more or less efficient. And so in the pursuit of simplicity, I think we can't let that, we can't have it both ways. There's probably going to be a trade-off there. And then the last thing is, going back to earlier comments, almost everyone said episodes, maybe with one clear exception. Most people said episodes, and they came right up to it and they said some episodes, some type of interaction, and they left it there. And again, let's see what we learn tomorrow. But I do think what I took away from that is whether it's 3 or 5 or in the commercial or in Maryland or, you know, from our kind of higher level policy from this morning, it's there. So I tend to agree with Lee, you know, it's there, but really taking that the next step in a very practical way, I'm channeling my inner Larry here, I think is really critical for us. Not that it's not important to hear that, but I heard that repeated enough, though nobody stressed it. And I would love for us to take the next step in figuring out, so what does it look like?
Jay, your hand is up. No, hand.
Put it down.
Okay. Chinny.
A couple of things I didn't hear. One was the waste, right? So everyone talked about healthcare and specialty, primary care, capitated. No one talked about how much money the healthcare dollar spends on stuff like RCM collection, you know, on things like eligibility. So if you look at a dollar slide, right, I remember in the statistics, it was like 10 cents went to the doctor, provider workforce. So I think what always confounds me about these conversations is that you can have the same amount of money go to the providers and doesn't necessarily have to, if you just looked at the simplifying the models and taking out some of the other crap, right, or waste. The other thing is that I didn't hear was speaking to, you know, most of America lives in, or geographically anyway, lives in rural areas where there is no primary care physician. So speaking to what Angelo said, what do you do with healthcare? How do you capitate to a primary care physician when there is none? There's a lot of places like I work, you know, the company that I work for, we're in a lot of places where the pharmacist is the only healthcare entity in town. So forget specialists, they actually don't have primary care docs. So then how do you solve for that problem? And so I think it felt a lot like we were solving for areas that are familiar, I think, to all of us, you know, suburban America, but most of America isn't there.
Thanks, Jenny. Angela?
The last comment I wanted to make was I also heard some comments during the discussion today regarding if you create the appropriate payment model, then things will align themselves and follow. And then I heard other comments there that wasn't true. I probably lean on the side of that's not necessarily true. I think the payment models give you the ability, and I heard the word freedom. I like the word, you know, he kept using the word freedom, to create the kind of care models you need and gives you the freedom to pay for them the way you need to pay for them. I think that's a strong takeaway from today, that really the key to success is the team-based care and the care model. And then we need the freedom from the payment model to allow us to accomplish those things within the care model. So,
Thanks, Angela. Jennifer?
What I like about discussions like today is it shows a practical polarity of how challenging this is. And what I mean is, we had academics and policy experts, much to Chinny's point, that talked about the challenges regarding benchmarking and risk adjustment and attribution, all of which are totally appropriate. And then we had someone only in the long-term care space talking about basic blocking and tackling and how hard that was and how there's been nearly a decade's worth of work, and they are just at the base of sharing data and how challenging that is. So just wanted to acknowledge again that I hope that we continue to not only surface what might be an approach from a policy perspective, but also how we might be able to help from a practical perspective, recognizing these many issues that we've covered over these educational sessions are not just about suburban America, where there's a high rate of commercial insurance that may impact the local Medicare population.
I'll just add Josh, go ahead, sorry.
Yeah, just a quick comment. I want to circle back on what Angela said, and totally unsolicited. I tend to lean on that side as well. I think, incentives are really about goals and internal, external goals. And so the implicit idea here is that the goal would be to create revenue in such a way to forward the kind of organizational mission. That's an important one, of course. But I think it's fair to say, as clinicians around the table, that clinical teams are driven by many other things besides that. Being a good kind of citizen and team member of the group, a guarantor of societal resources, an advocate for your patients, a practicer of evidence-based medicine, feeling a sense of mastery and autonomy in the job. I don't think those things are directly designable per se in a payment model, but I think we should acknowledge that those non-financial incentives can be subsumed if the payment models aren't set up the right way, and not assume that most people walk around as, homo economicus, thinking about, their margin and utility all the time.
You're speaking Bruce's language there. Margin and utility. Just a few additional comments. I was thinking about the conversations. I was thinking about the comments around CJR. Alice particularly said, it's probably the most successful program. There's a lot of reasons for that. And then there was another comment about, the incentives really should be more at the system level, not at the provider level. But I have to tell you, having implemented the CJR, the incentive to the provider was a major engagement in moving that to be successful. So it's not clear to me. I think it's hard to, that one's easier to put an incentive to a provider. It's clear they did the surgery, other things are obviously not as clean, but it was a clear example of how a financial incentive, which of course is coupled with, it turns out to be better care for the patient in terms of coordinating care, keeping them out of subacute rehab and others, sending them home, all those things that also aligned. At any rate, so I do, in terms of how do you engage specialists and then where the incentive lies, I think we still have a lot of, room to understand that. And then I know we talk about this at every meeting. I brought it up a little bit in some of the questions around data. I still don't feel, Intermountain, again, it's more in the model that maybe they can have data that they can provide more real time just because of their system. But that's not most places. And most places, if they're in a program, they are relying on claims data, which again has a huge lag. And if they're and their current priority, I don't think really has them invest in the EHR data in a way to get that to the providers currently. So that timely data piece, which we hear over and over again, is still a major challenge to sort through.
I'm surprised that turnaround of data is not a core MA competency for payers when they bid for MA plans, because most MA private payers, their data turnaround time is actually worse than CMS.
Yeah. That's true. Okay, we're approaching time for, yeah. Any other comments? This has all been really helpful. Walter, we haven't heard from Walter.
I've just been soaking it in, and a lot of the comments that I wanted to make were made. Okay. I just end with maybe a word of hope. We heard from LTCACO, and one of the things I really appreciated about their presentation was they actually went through the numbers. I keep on saying, I want to see some numbers, and they actually showed us some numbers, saving between $3,500 and $5,500 per beneficiary off of like a $30,000 baseline. So you could do the math, 12 to 16% savings, and I think that just kind of shows what can be achieved. Now, granted, it's a very specialized population, but what can be achieved with the value-based journey that we're on.
Great. Good. Thanks, Walter. Okay, so we're just about at the time where I'm going to ask Audrey McDowell from the PTAC staff to walk us through slides on potential comments for the committee's report to the Secretary based on this year's work. Committee members, you have a copy of these potential comments in the left pocket of your binder. As Audrey goes through the slides, you can flip your name card up if you have comments. So, Audrey, I'm going to turn to you.
Thanks, Paul. And actually, the slides are in a tab in your binder.
Okay.
It's the second to last tab. So as you know, this is the third in a series of 3 public meetings that PTAC has held related to development and implementation of population-based total cost of care models. PTAC will be developing a report to the Secretary that summarizes what the committee has learned during these 3 meetings, and will be including specific comments and recommendations to the Secretary as part of that RTS where appropriate. In addition to thinking about what you have learned today, we also want to have a structured discussion over the next 2 days about potential comments that you might want to include in the RTS based on what you've heard across all 3 meetings. And so we have provided, to facilitate this discussion, we'll be walking through some potential comments related to a list of topics that loosely generally follows the organization of the PCDT's overview slides. As we know, the topics in the overview slides were not meant to be exhaustive, so there could be additional topics that you might want to add, and these potential comments also are not intended to be exhaustive. They're just designed to elicit your feedback so that the staff will have a sense of what we want to do in terms of your comments for the report to the Secretary. So having said that, Amy, if you can pull up the slides, that would be helpful. So again, if you look at I think it's slide 3, you'll see that we have an outline of topics that more or less follows what we discussed with the PCDT: desired vision and culture, definitions, desired care delivery features, enablers to support the desired care delivery features, desired payment features, enablers to support the payment features, model design considerations, and desired performance measurement features. This is also potentially a structure for the report to the Secretary, but again, we look forward to any comments and suggestions that you have related to the topics themselves, as well as the organization of those topics. So if you could, Amy, pull up slide 5, that would be great. We want to just review the list of the desired vision and culture points that the PCDT had identified. And I'm not going to read each of these items. What we're going to do is just kind of give you a chance to look at what's on the slide and see if there's anything that you would add. So you already heard from the PCDT about desired vision and culture. We want to see if, based on anything that you heard today or any additional thoughts based on what you've heard previously, is there anything else that you would add to the desired vision and culture for value-based transformation?
Yeah, Jennifer.
Audrey, can you just clarify for us? I assume all the comments we just made will be translated.
Correct. We will be translating those. And so, correct, exactly. Right. So that's part of the challenge, is that these slides don't take into account what we are learning over the next 2 days. Right. So hearing none, I assume we can move forward. Okay.
Hold on 1 second.
Oh, okay.
I see these were lifted off the CT slides, which I like. Number 7, though, strikes me. It doesn't, as worded, it doesn't really describe a vision and culture statement. It's more of a tactical operational statement. So we might think about rewording that differently or striking it from the list either way.
Okay.
I think parsimony, somebody used that word earlier. It's one I haven't seen in a while. It's a desirable feature of almost anything. So I think striking might be a good idea.
And I don't know if this belongs in vision or not, but for me it certainly does. It's for us to be able to risk stratify and base our care on data-driven processes. I mean, that really should be driving a lot of our decision making. Maybe that's not in vision and culture, but to me it's certainly culture to make data-based or data-driven decisions as opposed to anecdotal decisions.
Well, I think, Angela, one way to work that in may reflect some of the conversation at the prior meeting here, which was moving actionable, timely data to the health data utility concept. That's a vision and cultural statement to work towards.
I mean, Angela, you could just add it to number 1. You know, culture of accountability for clinical quality, equity, and cost outcomes based on actionable data.
Yeah, Mike could do add it to that number 1.
Okay, any other thoughts on this slide? Okay. We'll be going back and working further with the PCDT after this meeting to further refine the comments, and then coming back to the committee to make sure we've captured what you've said. If you can move to slide 7. So again, this is from the PCDT presentation. We just want to confirm if you have anything else that you would like to add to, this is subtopic 2A for anyone that's looking through the document. Anything you'd like to add to services included in total cost of care. This is related to core benefits, supplemental benefits, pharmacy benefits. And again, this is at a high level. The actual report to the secretary will have more detail, but trying to capture what kinds of statements you might want to make to the secretary.
Jennifer?
I'm not sure if this is the right place to capture it, but there was conversation today in our previous sessions around capital costs. You know, actionable data is one we focused on a lot, but in our care coordination sessions, we also talked about infrastructure costs, and we heard a little bit about it on our long-term care example today from an ACO perspective. So if it's appropriate to add that as a call out.
Okay, anything else?
You know, the first bullet point about defining TCOC as including Medicare Part A and Part B expenditures, does that conflict with our working definition of TCOC models, which assumes accountability and for quality and TCOC for all covered healthcare costs? So, in other words, also Part D expenditures. We kind of touched upon this in our admin session earlier this morning, but there's some discussion on PBMs and drug costs and device costs.
So I think the reason why it's written that way, and I think this was part of what you guys had said back in March, but obviously we've evolved since March, was that TCOC is currently defined in Medicare APMs as including the Part A and Part B, but obviously we've heard discussion about the importance of the Part D expenses. So I guess you guys need to figure out what you would want to recommend to the Secretary regarding that. But then there's also been discussion that, there are complexities in adding additional services to TCOC.
I had the same thoughts as Walter when I read it at first, but your last major bullet does address that. So that's why I felt like it was at least represented on the slide.
Yeah, I think another potential way to address Walter's point is in the third bullet in the long term, the end of it says, well, the definition of TCOC should be allowed to differ. I think what we're hearing here is that they can differ even now, so it may be helpful to pull that concept up and in the short and move that into like a nearer term issue, but leave it the way Walter talks about in the last bullet.
Yeah. I know we'll continue to have a conversation back and forth in this, but I would encourage to leave it out and leave the bullet point about consider testing the impact, considering models where it could be included. But the reality is that the vast majority of Part D costs are not in the control of a physician team, no matter how well they coordinate it or care manage a patient. It's contract prices, and Medicare's negotiating those, and there's just way more influences that exceed any physician's ability to influence.
Any other thoughts? Okay, let's move to the next slide, subtopic 2B. And again, this was an attempt to list some things we had heard about financial and non-financial incentives. We've just heard you guys talk a little bit earlier about some of the non-financial incentives. But if there's specific things you want to add now, you can let us know.
It's kind of covered, Audrey, but so on the next slide where it talks about encouraging the high-touch team-based models, somewhere, I guess I'm questioning, is there need to be a bullet around somehow financially incentivizing that to happen? Because we say it should happen, but we're not. And it's implied, I guess, that somehow financially we need to support that, but it'd be clearer to put it in this slide.
Yeah, I agree with Angela's comments. And on slide 8, at least from my opinion, again, I don't know that you can design morale and autonomy in, but I think you could envision payment models that could counteract those. So maybe just a few words about either accounting for that in payment model design might be useful.
Still on slide 8, subtopic 2B, I think the second bullet point is interesting. And agree that it's there, but that glide path, all the speakers spoke to the glide path is a value-based model. There's just it starts with no downside and limited upside. We didn't hear anybody say that glide path should be fee for service with a pay for performance bonus, or should be a shared savings model. You never heard those words uttered today. And so the glide path is you are in value-based payment with everybody else. It's just you start with more up, less down, and gradually shift over time.
So should we put make fee for service uncomfortable?
Very.
And, you know, I think the sense of that is, I mean, maybe this is obvious, but one of the reasons we're doing it is to encourage them to go into value-based payment models, you know, make it uncomfortable to stay where they are. So I think somewhere that concept should be represented.
Okay, anything else? All right, we can go to slide 10, which is subtopic 3A. And again, this is just going one by one through the items that the PCDT had identified as desired care delivery features and identifying some potential comments that you may want to make, but feel free to refine or take things out, make revisions. Okay, let's move on to slide 11. Balanced use of and coordination between primary care and specialty care. Now, I anticipate that's one where you are likely to have more to say both today as well as tomorrow, because we'll be hearing more about that.
This is a bit of a minor comment, but just in the first bullet related to PCPs playing a major role in reducing costs, I might just consider addressing that. The reasons for that include, I think, what Jay and others have described as an investment in primary care and not tying that too much to cost reduction. Mike Williams talked about how there are cost offsets for preventive care, but it ought to be something we should do. So I'd just be wary of that as we word it.
Yeah, the same sentiment. I feel like we should remove that part of the sentence.
Bullet number 4, it's more of a tactic.
So do you want to delete it?
Well,
it does speak to, you know, the balanced use of, right? So you're right. It's a way to be tracking and judging your balance.
It's a tactic, though.
To Larry's point, it is a tactic. Yeah.
I like the idea of keeping in the sentiment, though, that we heard at our last session around models that were highly effective in terms of outcomes, cost reduction, and quality, that described actually high utilization and high from an engagement perspective and touches. So maybe I totally agree with you around the tactic is monitoring the data, but some have this principle of actually there's more work being done by different members of the care team that can be highly effective and reduce costs.
Yeah, but the bullet doesn't tell us what to do with the data. It just says to monitor it. So.
Right, but I think Jennifer's suggesting to call out the piece about the multiple encounters and the value of the high touches and yeah.
But it should lead to an action. It should lead to an action and not just monitoring it.
Yeah, no, eliminating the monitored data from, as you said, but keeping the part about the value of the multiple touches is an effective way of coordinated care. Yeah.
And to the extent that reflects coordination, there may be a way to incorporate that into the bullet below related to coordination and alignment between primary and specialty care providers.
Yeah, I was thinking combining that with the bullet point below and just putting improving coordination and alignment, including high touch care when necessary between primary care and specialty.
So my only concern about combining those two is that refocuses it on doctor-to-doctor touches, when I think we really need to be moving to non-physician touches.
Right.
And so how do we highlight both of those ideas?
Mm-hmm.
So.
I was thinking the same thing, but maybe by calling it care team as opposed to provider, which I think we're not saying explicitly, but we should.
Or you can keep it separate and take away the data and talk about encourage care team based care or high touch care as appropriate.
Okay, anything else on that slide? All right.
Somehow the last bullet just still strikes me off tone as to incentivize specialist participation and engagement with. It just really sounds like you're throwing money at the specialists to get them to take the primary care doctor's phone calls. So somehow we're talking about including, we're baking into the model specialist coordination and involvement. Concept is sound. The word incentivize, I think, especially is a fee for service sounding term. So we want to just reword that a little bit.
Or eliminate it, because you've already got specialists and primary care physician coordination and consultation already in 2 slides, 2 bullets.
Okay. Anything else on this slide? All right, let's move to slide 12.
I guess what I'm thinking on this one, we heard this again from our long-term care presenter today, but we've heard it in the past, and that's, and maybe it's because I'm in the quality and safety space, but an adverse health outcome is unexpected or unanticipated, where as we age, there will be progression of disease that we cannot prevent, but try to mitigate. So something that's, what we're trying to capture is that these complex patients require a special focus, special care team, special resources that may be different from other patient populations, but not necessarily mitigating adverse health outcomes. But that it doesn't, I don't think, fully describe what we're trying to focus on.
Just as a point of order, I don't know that you can say rising risk in the first bullet and then have quote marks around it in the last bullet. Couldn't you just say, make it a little simpler, use risk stratification to identify needs, coordinate care, and manage transitions? I don't know why you need to say high risk, low risk, rising risk, because it's a continuum. It's not three different unique things.
Okay.
Yeah, I was going to make the same point, just strike that with high risk, low risk, or rising risk, make it read right, because you use risk stratification for all kinds of reasons in a population health model, and it's not those 3 discrete categories often. On the third bullet point, balance focusing on reducing costs on high-risk patients and increasing investment in primary care. I think that is all true. The phrase for lower-risk patients. The investment in primary care isn't focused on lower-risk patients. It's just investment in primary care to achieve short and longer-term reduction. So I would just strike that phrase for lower-risk patients.
Okay.
I was going to say just quickly, I think the title has complex needs in it. We don't really call that out in the bullets below, so maybe some way of working that in. I also think saying risk, but not saying risk of what, like costly care or again, bad outcomes, I think to the degree that we can append that somehow throughout the slide would be good.
In terms of the targeted population-based interventions for populations with complex needs, LTCACO today did say there was a big focus on using palliative care, advanced care planning discussions, even hospice in this population. I'm not sure if you wanted to call this out here, but I think there is a big trend toward that right now.
So maybe that part of what this slide was trying to get to was, at least in the data that we've looked at over the years, those high-risk complex patients that have intense care management around them actually have fewer gaps in care than that 70% of the patients that are out there that aren't being managed because nobody's managing them. So ignoring that 70% of the population is probably not a wise thing to do. So somehow in here, identifying that there needs to be some type of gap closure, data process that identifies those patients, gets those gaps closed, I think is probably what this was trying to get to. So somehow leaving that in there, I think would be good.
Okay, anything else? All right. So moving on to slide 13.
Again, just minor, but again, I think in the second bullet, when we're talking about high-risk patients, at least my interpretation is high risk of having care affected by social drivers of health, which is distinct from the prior slide. So I would just try to make that clear. I also think in the third bullet, we say in the near term, which makes me want to read in the longer term. So I think we actually get at that in the latter half of that bullet, but may be useful to add.
And we may not be mature enough yet to incorporate this, but typically when we're talking about social needs and social determinants of health, we're talking about identifying those and referring those. We rarely talk about expecting some outcome or holding somebody accountable for that. And so there's this missing piece around accountable communities there that somehow we need to begin to incorporate into our models and our thinking.
So one of the things that came up earlier today was incentivizing partnership with community organizations. Do we want to craft some language around tying reimbursement, for example, in ACO REACH, where it's tied to that, tying reimbursement towards actually having those community partnerships?
I like that.
Yeah. So we did hear really clearly this year as well as previously about the real issue of navigating to nowhere. So the step really beyond incentivizing screening or incentivizing partnerships is how are we actually investing in building the system of response, and how is that system sharing in the accountability or rewards for total cost of care.
I guess that relates to, I'm struggling a little with the first one where it says the priority is making referrals in a way that minimizes provider burden. I mean, that is important, but I think making referrals that are are effective and to the point of and minimize provider burden. I feel like there needs to be something else there about the referrals and the process being effective for the patient, and then adding them minimizing burden.
Yeah, that could actually be two different bullets, because I can tell you that referring to the community-based organizations is extremely administratively burdensome and problematic. And so incentivizing processes to streamline that would be good.
I was just going to point out that adding the phrase "making referrals" in that first bullet, that's a tactic. That's one way to meet social needs. It's not all about referrals. Really great care teams have the people in the team that can meet some of those needs, right? So I might just strike that clause. The rest of it works.
Okay,
I really do appreciate the third bullet and trying to come up with a defined social needs screening instrument. There's just not a PHQ-9 of social needs yet, and I don't think most operators care which one they need to use. They just hate 4 organizations making them use 4 different ones.
Yeah.
Okay. We are almost at 4:15. Do you want to do another slide, or do you want to?
Do we have time tomorrow then?
We have time tomorrow. Yeah.
Committee's consensus is defer the rest till tomorrow. Okay. So with that, I want to thank everyone for participating today, our expert presenters, my PTAC colleagues, and those listening in. There's more to cover on payment considerations and financial incentives for total cost of care models. We'll be back tomorrow morning at 8:45 a.m. Eastern. We'll feature 2 listening sessions as well as time for public comments. We hope you will join us then. So thank you, and this meeting is adjourned for the day.
Produced by the U.S. Department of Health and Human Services.